We're just waiting for this YouTube to be connected.
Yep, it's just taking a minute, sorry. Okay, we are now live on YouTube, so I'm going to start the webinar. Okay. All right, Chair, we are set to go, and we do, you may call the meeting to order.
Thank you. We call the meeting to order, and welcome to everybody. Could we run the roll call?
Yes, absolutely. We'll get started with the roll call. Commissioner McAllister.
Present.
Thank you. Commissioner Chair Khan.
Present.
Thank you. Commissioner Roa Dugan.
Present.
Thank you. Commissioner Grady.
Good morning. Present.
Thank you. Commissioner Van Houweling.
Good morning, everyone.
Thank you. Commissioner Bond. Commissioner Tyler Garner.
Present.
Thank you. Commissioner Winkler.
Good morning, present.
Thank you. Commissioner Vice Chair Rubelid.
Good morning, present.
Thank you. And Commissioner Ralston.
Morning, present.
Thank you. And for the ex officio members, we have Marla McDade Williams for Richard Whitley. She's Deputy Director for the Department of Health and Human Services. And then I would like to ask, do we have Barbara Richardson on the line?
I'm here. Yep.
Thank you. And then Ryan High from the Silver State Health Exchange.
Present.
Thank you. And then Laura Rich with the Public Employees Benefits Program could not be with us today. And Chair, you do have quorum and you may proceed with the meeting.
Thank you. Appreciate it. So the next item on the agenda is the approval of minutes that needs action. Do I have a motion to approve the minutes? Anyone?
I'd like to pick up. Oh, go ahead, Commissioner.
I motion to approve last month's meeting minutes.
Is there a second?
And I'll second that, Mr. Chair.
Any
Mr. Commissioner.
opposed? Any opposed? If not, motion carries. Next item is public comment. Melinda, do we have any public comment in person or in writing, north or south?
Yes, so I do have public comment. I see Patrick Kelly has raised his hand. And again, please press *9 to raise your hand if you need to. And Patrick Kelly, I'm allowing you, please go ahead.
So just a reminder, we have 3 minutes for the presentation for public comment. I would appreciate the respect the timing. And please identify yourself and who you're representing.
Good morning. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. I'd like to speak about access to care. Healthcare in America is extremely complicated and fragmented. If we were to sit down and design a healthcare delivery system, we certainly wouldn't design the system we have today. Our healthcare delivery system has morphed into a giant entanglement based upon reimbursement rules, skinny networks, and ad hoc regulations. That's why it's so difficult to fix. When you pull or push in one area, it affects other areas. The PPC was charged with 3 things. The first was quality, the second was accessibility, and the third was cost. In past meetings, the PPC is focused on cost containment. Today, I'm asking you to focus on access. For without access, neither quality nor cost is relevant. Without access, there's simply no care. Please be aware that when you contain growth, you may inadvertently decrease access. Nevadans already have poor access to healthcare. How many of us have experienced extreme wait times to see a physician? 63.7% of the state's population resides in a federally designated primary care health professional shortage area. These shortages aren't limited to rural areas. In fact, the percentages are higher in the urban southern and urban northern areas of the state. When the state increases access to primary care, the need for access to more medical specialists and specialized facilities will increase because more illnesses will be diagnosed. We must assure that adequate levels of primary care and secondary care are available. So what are some of the unintended consequences of cost containment? Health inequities grow among Nevadans, poor management of diseases, especially chronic diseases, and unnecessary disability and premature death. Our request is simple. Before acting on anything, please examine the potential impact the proposal will have on access to all citizens now and in the future. Thank you very much.
Thank you. So any other public comments, Melinda?
Again, please press *9 to raise your hand if you have public comment. And not seeing any, Chair.
Did we get any written public comments?
I've not received any written public comment. Thank you.
All right, thank you. So moving along with our agenda. The next item is for possible action, reappointment of Stakeholder Advisory Subcommittee of the Peterson Millbank Program for Sustainable Healthcare Costs and suggested members list attached. Now, as you all recall, the potential list has been distributed by Melinda more than once. At least I got more than one email to all the commissioners. And we are hoping to take some action one way or the other. Unless any commissioners have any objections or reasons to not take action, please let us know right now so that we can decide what to do with this item. Any commissioners have any additional questions, reservations?
Please raise your hand.
Is there anybody raising hand, Melinda? I can't see.
I do not see any commissioners with their hand raised.
I'm trying to raise my hand. I'm sorry. I'm trying to move my computer at the same time as Commissioner Bond. Can you hear me?
Yes,
Yeah.
Commissioner Bond, please go
Okay.
ahead.
I'm sorry. I missed a beat there, Chair Khan, in the request. We're trying to take action on the Stakeholder Advisory Committee.
Right. Unless somebody has questions or reservations.
I continue to have reservations. I feel like I think that we should be discussing more the intent of the advisory committee, and I think that we should be taking a pause on it until we get these bill drafts into the legislature and can really focus on the goals and the potential value of the advisory committee, and then can consider its structure a little better.
Okay, thank you. Any other commissioners have any comments in agreement with Commissioner Bond or otherwise?
This is Commissioner Winkler. I agree with Commissioner Bond. I especially want to know more about what our updated timeline is in regard to the benchmark, so we can really understand what input we will be seeking, because we've developed what the total healthcare expenditure, what factors we're looking at. So I kind of want to know what our next steps are. I definitely want to seek and get that input, but I think we could spend a lot of time on this, and I don't want to give it short shrift because I do want to really focus on our BDR topics today.
Okay, thank you. Any other comments from commissioners? Because I think if there are at least a couple of people are uncomfortable with the proceeding, we may take a vote to table it or otherwise. Any other commissioners want to express their opinion?
This is Commissioner McAllister for the record. I'm in favor of approving the advisory subcommittee. I enjoy listening to their conversation, especially before we have conversation, and I believe it allows people to have input on the record for something that is important to them, both from either their work perspective or as patient advocates. I am strongly in support of approving this today.
Thank you. Anybody else wants to make a comment? I think we may end up taking a poll from the commissioners. Anybody else wants to give their opinion before we go that route?
Commissioner Ralston, I see you have your hand raised.
Yep, thank you. So Commissioner Ralston, for the record, I just would really like Chair Khan to hear from Melinda her current workload and resources, because I would be remiss if I didn't also ask her about her time and her resources managing another subcommittee that's subject to open meeting laws, and what the value of this stakeholder is, especially considering that I know that you are shifting your administrative roles, and Leslie departing, and I think you have a new analyst. So, I'd like to hear from you, your current workload and resources, and if this is something that is manageable, or if it would be better for you to free up some of your time to also pause this until the commission I just want to make sure the commission understands that the value that this has, or the burden it has on your current workload.
That's a very good point you raised, Commissioner Rawson. Melinda, you want to opine on this?
Absolutely. Thank you, Chair. And thank you, Commissioner, for the question. I do believe that, with the open meeting law and managing to a commission and a subcommittee is an increased workload with Leslie retiring, and bringing on a new staff member has been wonderful. I want to say that I do have the ability to do that if that is the need of the commission to manage this subcommittee as well. I do want to keep in mind that we have, our BDR topics that are going to be going forward, and a lot of communication and information on those topics will be as we move forward into legislative session. And so I want to be that supportive role for you all, and note that I can do both of those things if you need that. And again, the role of this subcommittee is really to opine and bring forward good recommendations to this subcommittee, or to this commission, I apologize, for the Peterson Milbank Program for Sustainable Healthcare Costs and the Cost Growth Benchmark. And so with that being said, I want to make sure that everyone, whether they be from industry, the community, or the patient perspective, really feels that they can still voice their concerns and have continued engagement with all stakeholders involved in this work. So if the will of the commission is to either move forward with this subcommittee, we can do that. Or if the commission would like to pause on this for a moment, I would like the opportunity to develop a stakeholder engagement distribution list to continue that ongoing engagement and to solicit feedback and comment from this important group. And that would be my opinion. So thank you so much.
Yeah. So is there like a happy medium, and maybe the DAG can weigh in, because I think it's extremely valuable to have an open process and solicit feedback. And particularly, I was just wondering if the role of the subcommittee, are you getting continuous engagement, or if you're just getting feedback? Because if it's feedback and sharing of information, is there a way to make it a little bit more efficient and streamlined? And I would actually be in favor of maybe moving this into a stakeholder distribution list or situation in which you could still share all of the information, all the meeting, and still request for their feedback and individual submission, and then share it with us, because I do see the value in Commissioner McAllister said, I think it's great to see their feedback, and I wouldn't want to miss out on the opportunity. I just think that I understand the burden that you have facing you with the legislative process and gearing up for the bill draft requests, which I know are going to take a huge workload, and it is a top priority of the commission to make sure that that's navigated properly. So I would personally be in favor of pausing this, really for your resources and opening up that, but I don't want to limit solicitation of feedback. So I would actually be in favor of two things, Chair, pausing this for continued discussion, maybe after the BDRs, and maybe bringing this up the next meeting or the following meeting. But for now, not limiting our executive director from reaching out to the current stakeholders, but maybe just moving this into a stakeholder distribution list in which she could solicit them for their individual feedback and report back to us. That would be my motion and suggestion for the commission, and maybe it's a happy medium for both.
Thank you. So there is a motion on the floor now. So is there a second for this motion before we go for additional discussion? Is there a second for Commissioner Alston's motion to table it?
This is,
And-
I second. Sorry, sorry, Commissioner Winkler. I couldn't tell if you're going to second it at all, or not,
Sorry.
because it was your, I think it was consistent with what you were already saying.
We have a motion and it was seconded. So any other additional comments? Otherwise, we'll proceed with the vote.
Yeah, I just had a slight clarification on the motion. So the existing stakeholder committee expired. And so if we don't approve this stakeholder committee, I don't know how we could use them in a distribution manner. So I think we first need to possibly approve the committee that's been suggested, maybe pause on meetings and switch to a distribution feedback model, if that's an option. Does that make sense?
Yes, any other opinions?
Commissioner Bond?
If we were going to do that, wouldn't we want to include the expired committee members? Because I'm not sure how the advisory committee was changed. It could be that there's advisory committee members on the expired committee that want to participate and would be, want to be included in a distribution.
So I don't mind modifying the motion to continue with the subcommittee as is, no change in membership, but adding in the additional members suggested, all of them on the distribution list, and then continuing to move forward with the current existing subcommittee with no meeting, but moving to a distribution list and adding everyone that was on the list or suggested. So that way it's all encompassing. It includes the existing members, and I believe you still have their contact information, as well as everybody else that has been suggested. So that would be my motion for clarification.
Want to endorse that amended?
this is Tyler, I also second the amendment.
Okay, so we have an amended motion, and just for clarity, as I understand it, so there will not be any formal meetings of a subcommittee given the point raised for Melinda, et cetera. And there'll be a distribution list which will include the former members and some additional people that will get the distribution of issues from Melinda. And if they want to give input, they can give input in a public meeting, as I understand it, or give it in writing to Melinda for discussion and future references. Is that a correct understanding?
Yes.
Okay, so then we should proceed with the vote then if there's no further discussion. Melinda, you want to just take a quick hands up?
Sure. So let's see. All right. So all in favor of approving the amended motion as presented, please raise your hand. Okay. And I am seeing all commissioners' hands are raised in approval, Chair.
Okay, thank you. Motion carries. Thank you very much.
Just for the record, I didn't raise my hand.
I apologize, Commissioner McAllister.
Okay, thank you very much. So we'll move on to the next item for possible action, review, and discussion of bill draft request topics. Just a little word of suggestion is that if these are intense discussions from our past experience, and in the interest of time, if I may request the commissioners to focus on their specific points that they may want to raise raised about the language of the bill draft, any changes, modifications, or amendments into that, so that we can move it along in an efficient manner. I would ask Melinda to start the process. We would need the draft read out. Just one more comment. So from our previous polls, there were the top 5 bill drafts that were polled. We are looking at the top 2. That doesn't mean the remaining 3 are eliminated out of the 5. There's a potential for a third BDR, and one could still opt to pick one more BDR out of the remaining 3. But if we can focus on the top two and get them out of the way, then we can come to a potential BDR 3 out of the remaining 3 topics. So Melinda, you want to get started with the first BDR proposal?
Yes, absolutely. I did note, Commissioner Bond, you have your hand raised. Is that left over or did you have a comment? Okay, perfect. All right, we'll go ahead and get started. So for this item, I wanted to again start out with a roadmap of the discussion and possible action for this agenda item. We will first discuss the 2 BDR topics with the highest number of responses, as mentioned during the July meeting. So we will take these topics, the first 2 topics, one at a time. I will initially give an overview of any new information provided for the topic as was requested during the July meeting, and then ask for any discussion. After discussion, Chair Khan may call for a motion. We will repeat that process for the first 2 BDR topics which are here, subject to topic 1, and then for subject 3, topic 1. Then we will move forward to discuss the remaining 3 BDR topics with the higher number of responses. I will again give an overview of any new information that's provided for each topic and ask for discussion on those topics. After discussing the remaining 3 topics, Chair Khan may call for a motion. The goal for today is to arrive at a final decision to request the drafting of not more than 3 legislative measures which relate to matters within the scope of the commission to the Legislative Counsel Bureau. Once the PPC makes the final decision on up to 3 bill draft requests for the 2023 session, I'll then compile the information and submit to LCB before September 1st. Once the PPC BDRs have been submitted, they will then be in the hands of the legislature, and unless decided otherwise, the commission will take no further action. My role will be to ensure the language meets the intent of the request as you will decide today. I will be working with the legislature and will share the process along the way. You will receive information as I am given, and I will continuously solicit your individual feedback. Meeting updates will be for discussion purposes only. This process is designed to manage the expectations and realities of the Nevada legislative process and our responsibilities to follow open meeting laws in our state. As we move into this discussion, please also utilize the PPC BDR overview and detailed documents which are provided in your meeting materials to help reference during this BDR agenda item. Just as a reminder, we do have the PPC ex officio members available as subject matter experts if you have any related questions which come up during the discussion today. Now we will head into discussion on the first potential BDR topic, subject to topic 1. As a reminder, subject to topic 1 is to codify the Nevada Healthcare Cost Growth Benchmark Program as set forth in Executive Order 2021-29. And include a requirement to measure and report on primary care spending. After the July meeting, I gathered some additional information through an information request to multiple state agencies, as you can see on page 1 of the detailed BDR document. From that query, a few items I wanted to highlight. There are 2 agencies within the Department of Health and Human Services who will be proposing during the 2023 session a few new full-time equivalent, or FTE as we call them, staff to support and sustain the work associated with the healthcare cost growth benchmark. In response to the question posed to state agencies, if the state of Nevada were to implement a law requiring healthcare spending, monitoring, and reporting, are there consequences to any of the other programs you currently administer? The Public Employee Benefits Program, or PEB, commented that PEB does not have concerns regarding the implementation of a law requiring monitoring and reporting of healthcare spend. The data is necessary in order to better understand healthcare spending. PEB did also want to note some potential challenges in this space, which may result in the need to negotiate higher reimbursement rates for specific types of providers in Nevada. However, I do not necessarily see this as negatively impacting the benchmark reporting or PEB, and I'm more than happy to have these conversations with PEB and other health insurers as appropriate to help mitigate these or other concerns or potential foreseen challenges. Otherwise, there were no added state agency comments to this posed question. Lastly, the PPC Deputy Attorney General, or DAG, confirmed that if the PPC wants to codify the program in statute, this must be accomplished through the BDR process. I would now like to open this BDR topic up for discussion. And Commissioner Bond, I see you have your hand raised.
Yes, I don't want to stop your flow. I just have a couple of logistics questions about the use of LCB and our interaction with LCB. And I believe we've had some support from LCB in the meetings before, but maybe we could talk about that next. I just don't want to move out of today's meeting without an understanding of the support we're going to get from LCB.
Commissioner Bond, could you clarify? I missed the actual request.
Okay, so before we actually, I guess we'll do it now. I'm sorry, Melinda. I did not mean to slow you down here. I think that I'm looking at these BDRs and I'm thinking that, you know, no matter, based on your comment that you're going to work with LCB on getting them drafted correctly, I think in the last session, before the last legislative session, once the BDRs were presented, once we discussed them, there was a lot of discussion inside the PPC about specific pieces of the BDRs. And I think we had at least one meeting where BDR legislative staff was on the phone or in a meeting. And I feel like we're kind of missing that on this process. So they were very helpful in answering questions about the process, but also about specific points in the BDR. So I just want to make sure that there is a step inside this process where we are able to talk to LCB about the BDRs.
So if I hear you correctly, we're proposing potentially having the LCB people come and give us their input after we have done what we are supposed to do today with these BDRs, and add or subtract from their perspective on the process that may entail in the legislature.
Yeah, I guess that's right, Dr. Khan. Thank you, Chair Khan. I would like us to have, number one, their expertise when we get close to drafting, and number two, access to the draft before it becomes final, so that we have a chance to review it.
That makes sense to me, at least, unless somebody has some other thoughts. But I think if hopefully we can achieve a goal of approving the drafts as presented today, at least on these two topics, and then get the input before it gets finalized from the Legislative Council Bureau, which will be the next meeting, then we would have approved a certain basic language today, and then they can come and say this is not appropriate or this is appropriate, you need to add this or subtract this, and only after that would we be able to finalize the language and then vote on that language after their input.
And they may not be able to do it by the next meeting, but before it goes into a final BDR, I would like us to make room for that, Chair Khan.
Requested, you never know, they might surprise us.
They do surprise us. Thank you.
All right, thank you. Any other comments? Okay, Melinda? Can you hear me?
I do not see any additional comments. You are free to call for a motion unless there are other discussion.
Okay, if there are no other discussions, let me call this for the motion. You may take the poll, Melinda.
Will do. Okay,
Keep
so
in mind, we are doing this with the caveat of what Commissioner Bond just mentioned. As long as everybody understands that this is the initial first draft that we are going to approve, this will be modified potentially or not down the road.
okay.
This is Commissioner Winkler. I'm just clarifying. Are we about to approve this topic, or are we just talking about how we want to continue working with?
This topic.
Okay.
Melinda, you may proceed.
Thank you, Chair. All right. So all in favor of approving subject to topic 1 as one of the PPC BDRs, please raise your hand. One second while I go through. Okay, I see all commissioners' hands raised in approval.
All right, thank you very much. Motion carries. Item number 2, Melinda.
One moment, okay. All right, so moving forward. So for subject 3, topic 1, briefly, this topic is mandating that all providers of healthcare and custodians of healthcare records implement an interoperable electronic healthcare record system. Expand immunity for provider compliance with providing and receiving electronic medical records. Revision of NRS 439-584 with relation to health information exchange and other areas identified. A more detailed description is also found in the BDR overview and detailed documents as well. Some additional information gathered on this topic includes that in response to a question that was posed during the July meeting regarding provider requirements to input information into WebIZ, the Division of Public and Behavioral Health State Immunization Program commented that all immunizations must be reported regardless of the funding source. So NRS 439-265 and NACs 439-870 to 897 govern Nevada's immunization information system, which is Nevada WebIZ, and require the reporting of all immunizations administered to all ages in Nevada, unless the patient signs a form to opt out of inclusion. If enrolled with the Nevada State Immunization Program to receive publicly funded vaccines, which are VFC, vaccines for children or otherwise, the provider must also manage their inventory quantities in Nevada WebIZ. In response to the question posed to state agencies, if the state of Nevada were to implement a law mandating that all providers of healthcare and custodians of healthcare records implement an interoperable electronic healthcare record system, are there consequences to any of the other programs you currently administer? The Division of Healthcare Financing and Policy, or DHCFP, commented that yes, as an insurer regulated by the Centers for Medicare and Medicaid Services, DHCFP is compliant with the Patient Access and Interoperability Rule. Additionally, DHCFP provides a mobile application for Medicaid members that allows them access to the Medicaid provider directory, pharmacy formulary, and their claims history. Otherwise, there were no added state agency comments to this posed question. Lastly, the DAG, our Deputy Attorney General, confirmed that, excuse me, any modification of statute needs to be accomplished through the BDR process. So I'd now like to open this topic up for discussion. And Commissioner Bond, I see you have your hand raised. Nope. Okay. Commissioner Winkler, please go ahead.
Hello, thank you. Just one clarifying point. I think we had talked about not using the mandating language, and that we were hoping to support the adoption of interoperable electronic healthcare record system. I'm not sure if where we had landed on that, if any other commissioner can comment.
I'm not sure where we landed either. So would that then reduce this down to just updating existing NRS? Because if we're not mandating anything, I'm not sure what we would need a BDR for. That's a question, not a, I don't know. I don't know the answer to that.
Commissioner Van
Chair,
Hollen.
thank you. This is Commissioner Van Hollen, and I appreciate the question, Commissioner Winkler, and clarification. I think the key in this is currently we have a system that allows for voluntary participation, but I think we definitely need to have mandating this. Otherwise, it's really not going to be very effective in allowing for interoperability and having a central repository. And if you don't require it, then it becomes really ineffective on what we're trying to do as far as improving healthcare quality. So I believe and certainly support that retaining and authenticating and storing electronic records in a central hub is the most effective way to allow the PPC to be able to achieve some of its goals on improving quality, access, and costs. That's why I would like the commission to consider mandating and allowing tools to assist patients to be able to access all their information, especially regarding claims data, diagnostic, their clinical care, lab results, and radiology. So if we don't have that, then it's really a non-effective system, which essentially we have today that's really fragmented and not inclusive. So, and certainly mandating is a strong word, but we would certainly, in part of section 3 of the main topic, would allow a provision to permit a 5-year compliance rolling in. Say hospitals like UMC or larger ones would be required year 1, providers, physicians over a 2-year, and certainly rural areas that struggle a little bit more, so we can figure out the financing a 5-year period. But it certainly would expand the interoperability that we're trying to do. So hopefully that helps, Commissioner Winkler.
Thank you, Commissioner Van Holling. Any other comments?
Yes, I see Commissioner Bond's hand is also raised.
Yes, based on, I just now would like to clarify a little bit of my understanding of the BDR based on what I just heard. I believe that we are trying to comply with the federal requirements that CMS has created to require interoperability and take it into the non-Medicaid market so that all of the physicians are providing an interoperable electronic health record. I do think we discussed whether 5 years would be a good timeline, and that's not in this draft, but it could be before it would be a mandate that we're trying to actually monitor. But I believe the part that we most wanted to mandate, or the thing that I'm most interested in mandating, is that providers have to make their patient records electronically available to the patient themselves. So I believe we should add just make sure that the notes to LCB are that, one of the focuses of this is really the patient access to their own medical records. And then in association with that, NRS 439-584 with the HIE might have to be altered, because we might need more than one way for people to get their records. And I think that there are issues inside the statute for HIE that need to be revised to allow for more than one sort of process to go forward, instead of just one state certified or one state allowed process. So I would say those two things should be added as around the edges, Melinda, and that's why I'm a little concerned about, we've got to see this again. So if you're going to add those two pieces, I would feel really like we captured the intent of this BDR in our conversations.
So if I may, to Commissioner Bond's point, I think that's a very crucial point you raised, Commissioner Bond. There are several components to this. First of all, the fiscal impact on the regular small provider. If it is interoperability records, they have to install programs, softwares, et cetera, et cetera. But if they are able to provide the patient, for example, their disc or their notes in the form of a disc, or X-rays or ultrasounds in the form of a disc, at least the patient has access to his or her own medical records that could still be carried to wherever this patient is going, short of this major implementation, which could be cost prohibitive to some of the smaller providers in the community, especially the rural community, for these providers to have an interoperability program. I remember in one of the discussions a year ago, the cost is significant in trying to develop an interoperable electronic software system. And there are multiple out there in the market, each one trying to oversell the other product. And then it comes to the standardization, even of those that are participating in the interoperable one. There is a format currently existing that some entities are in that interoperable program, which is fine. But another way, I think, as Commissioner Bond pointed out, patients should have access to their own records and they can carry it wherever they go. If they're going from here to LA, for example, for care, and if they're not a part of our system of interoperability, which a lot of times is a problem, if they at least have their disk of their patient's records in the in the computer with their doctor here, or diagnostic procedures, then that would be extremely helpful, even if they're going out of state. So to Commissioner Bond's point, whether some language needs to be added, to me, that's the point we need to talk about. What kind of language should be added to cover that concern?
So can I just comment on this real quick? So the way I read the way that this is written is first we want to mandate that providers have an EHR, an electronic health record system. And then
Right.
if they have one, we want it to be interoperable. So that's how I understood the discussion. The one thing I did want to ask for clarification from Mason on was this central repository concept, because I don't see that at all. And that's a totally different conversation. Creating that, managing that, all of that is just not something that I don't know who would do that. I don't know how we would fund it. And there's not a lot of, based on experience last session, there wasn't a lot of support for having a central system of people's health records, just for security reasons. And so I think I just want to clarify that wasn't the intent to have a central repository of medical records.
So to your question, which is a good point you raised, good majority of the providers, and I'm talking about the providers in the community, physicians and other providers, switch to EHR some sooner than the others. Now, if they are going to be interoperable, the current EHR system that they have acquired may not be able to do that. So which means another investment for them to adopt, modify, or purchase a new EHR system, which would then be interoperable. So that puts another burden on the common provider in the community. And that's why I think Commissioner Bond's point is important. At least the patient has access to her electronic component, disk or paper, whatever is feasible. It should be a disk, and every doctor is supposed to be on EHR. And that would at least cover the fact that they can carry the records wherever they're going.
Chair Khan, this is Commissioner Van Houweling. Could I make a comment and maybe some clarification for the rest of the commissioners? And so I appreciate the conversation, and I know we're trying to define Nevada's role and the federal role. In the 21st Century Care Act, there's a couple federal acts that really accelerated electronic health records and sharing of data, especially in the CMS world, the Medicare and the Medicaid world. So let me just start with, you had the 21st Century Care Act, which was really around information and preventing information blocking, if you will. And then you had the HIPAA, everybody's familiar with HIPAA, that really talks about, there's a lot of things within HIPAA, but in the HIPAA rules, there's things around patient access and patient portability of their own information. And then certainly, finally, the HITECH Act that's on the federal side really drove more electronic portability and access to information that drove all these programs that were meaningful use. So when we talk about meaningful use, that's more on the federal side. Right now, there is movements to be more interoperable. And I think that's what Commissioner Bond was referring to, is until we can get a repository, and we have that today, but it is not as robust as we would all like to be able to get some of this information through our Nevada Health Information Exchange. But to get to true interoperability, we really need to allow these medical records, and they're not as difficult as they used to be because a lot of the investment's already been, but to allow patients to be able to log in regardless of where they're at to get their information. And again, it's really around the demographics and the clinical care and the radiology and the labs. So allowing, again, for that patient to be able to have that information. But if not everybody participates, then patients will have limited information or no information or missing information for providers to be able to care for patients and drive down the cost and improve quality. So hopefully that clarifies a little bit more for the rest of the group.
Yeah, Commissioner Van Houweling, I agree with you 100%. The program currently as it exists, patient can carry his or her information with the password for access. And if they show up, for example, at UMC, the patient can give their access code and the UMC can see the patient records from elsewhere based on the institutions that are participating in that program. And same with the lab, and same with the ER visits that they can access with the password, etc. So that is ideal, no question about it, and needs to be expanded on and made more available with interactive programs between all institutions. My only concern is about the small providers in the community that may or may not be able to get into that system so easily. So at least there's a backup for even for those physicians that at least one should have access to, the patient should have access to the records from those providers, at least in some hard copy or paper or CD. For example, a patient comes to the ED at UMC and was seen in ED at another hospital. He can give the authority to access her records from the other hospital and with a password, and they can put it in the system and pull out all the records. That is an excellent setup for institutions. Same with radiology results and reports. Radiology outpatient tests done should be accessible to the patient when they're arriving in the hospital so that we don't have to repeat those tests and it becomes cost prohibitive by repetition of tests that goes on.
Yeah, Chair Khan, and this is Mason, and you're exactly correct. And really, and we can use UMC, but we can use Renown or any organization that has an electronic health record that has a patient portal. So there's really two ways. Whether you have Epic or Cerner or other programs, you can log in through the patient portal through that program. But also, if you don't have that at your fingertips or allowing the health information exchange, and we have that today. Just I want to be clear with the other commissioners that patients can log into our current exchange and get information if it was there for them through a password and username, no matter where they're at in the state of Nevada. If they opted into the program, if the patient opted in, and then, but also in order to have that, you also have to have the providers providing the care. And right now, we do not have all providers in the state of Nevada that are on electronic health record providing that information to the health exchange. So that's just a clarification of not all providers submit data to the health information exchange today to allow the patients to access their information in a real-time way.
Go ahead, who's next?
Can I go? Okay, thank you. I appreciate it. I think that we've had a couple of smaller conversations about this that I think coming back now to the full PPC, I think this is a good conversation today. I would like this subject 3 topic 1. I would like us to consider altering the language that's here. I really agree that trying to get another enterprise that creates a central housing for patient records is not realistic based on things that I've heard Sandy Raybould say before. And I would instead really like us to mandate that patients have to have access to their personal health records. And then they're in control of who they send those to. And then I'd also like us to say that, encourage that the providers over a 5-year time frame, the providers make their healthcare records, their EMRs, completely interoperable. I do completely agree with what Commissioner Van Houweling is saying about interoperability has become much easier. And that is one of the reasons that we wanted to promote this bill this time. It has been hard over many years to be able to consistently get records to talk to each other. But I think that with COVID, we learned a lot about it's not a 3-year multi-million-dollar project anymore. It's a 30-day, connection between EMRs, between agencies. I would just like us to do whatever we can to encourage that in conjunction with what's going on federally and not rely on one stream of HIE to do that, because I don't believe the state of Nevada is gonna make that work. I think we've moved past that, and instead of one river of an exchange, I think we should be making everything as interoperable as more like a spider web model as possible. But I think the thing that should be mandated is patients should have access to their health records electronically so that they can be in control of their decisions, because I don't believe that we've moved along on that as quickly as we should.
Thank you, Commissioner Bond. Any other commissioners want to opine?
This is Commissioner Winkler. I just also want to support that the idea behind this BDR is to really deliver something to Nevadans that they can use, that they have access to their records. It's easier for them to go to the correct healthcare provider. And then this does follow with the state of how CMS is saying we need to do this. And yes, as I in the detailed description of this BDR, that lays it out a little bit more, but I think that's one of the main things we need to emphasize, is that is the purpose of this: maintaining electronic healthcare records, making them available to patients, and that would include interoperability of those electronic healthcare records.
So thank you. And if I may comment, I'm talking too much, I shouldn't be, but it says here in custodian records, implement an interoperable electronic health system. We currently, at Commissioner Van Holling alluded to, there is a system which is interoperable, but it's limited and not participated in by everybody. And if we are mandating an interoperable electronic health system, there should be in existence an affordable, interoperable electronic health system, at least in the state of Nevada, which is also portable if they're leaving town. At least within Nevada, if we can accomplish that, what would be that interoperable electronic health system? I am not sure. I think Commissioner Van Holling is familiar because he's been one of the champions in this interoperable electronic system. If I may ask you, Commissioner Van Holling, what is your thought process? Is there one interoperable electronic health system that can be expanded and accomplish the goals we are talking about, or we'll end up with 2 or 3 such programs?
Thank you, Chair Khan. And I think what we're looking to do is allow for more information going to essentially the hub to allow patients to have that repository of information. So and back to Commissioner Bond's comments, I think we're certainly don't want multiple options. We want one really solid option, as Commissioner Winkler said, that allows Nevadans to access their information in real time, that's easy, affordable, at no cost to the patient, obviously, because information is just being transmitted from their visits, but certainly looking for one solution for the state of Nevada that could help us with our PPC goals, but ultimately help the patient. So is that correct, Commissioner Winkler, Commissioner Bond, as far as your vision as well?
Now, I would just like to clarify if I could. So the difference between the HIE and EHR is totally different, right? So we have one HIE in the state of Nevada. It's operated by a private for-profit company. Requiring providers to have electronic health records that would put the burden on the providers to have those EHR systems, and that those systems are interoperable. So it's 2 different swim lanes. And then we would further require that patients have access to their records through that EHR system. Now, those EHR systems can talk to the HIE, and the HIE can be the gateway to communicate if that's how providers choose to implement. But I think I just want to clarify that there is no one central repository of records that everyone can tap into to get records. That it's throughout the state in disparate EHRs. And then there is an HIE that is smaller. It doesn't include all the state's data or all patients' data. So I believe the intent of what we were trying to do was to require providers to have EHRs that were interoperable to help lay the foundation for future easier interoperability. So that's what I thought we were doing. So I just wanted to make that clear.
And I agree.
And you're correct.
I agree.
Oh, good. Commissioner Bond, if I could, yes, I think also, and this is just a comment, I don't want us to overthink the electronic health record in today's provider healthcare delivery world. it certainly is a requirement for meaningful use in CMS to look at data, population health, and all those things. So I don't think we're putting an undue burden on providers, because if you're participating in the public health programs that we certainly want to support in the state and the federal level, you need to have electronic health records to participate. And I'm talking Medicare and Medicaid. So you're exactly right. But I do want the commission to perhaps not overthink the burden of an electronic health record, because most already are doing it in compliance with the HITECH Act and some of the other things that are required to participate in Medicare and the CMS programs.
So thank you, Commissioner Van Holling. That brings me back to my previous observation in the language. Healthcare and custodians of records implement an interoperable electronic health system. There is none, as far as I know, a universal interoperable electronic health system as it exists today. There is this private enterprise, and then there are some hospitals and diagnostic services connected individually to each other. Of course, EPIC is one of the better programs, and Cerner to some extent in providing access to the patients, like Commissioner Van Holling mentioned. So where do we go? Are we going to suggest one electronic health system, which is practically and pragmatically, I think, a challenge? Or in absence of that, or if that is doable over a period of time, in the interim, what is our solution to provide records to the patients concurrently?
I think we have two parts here. I'm sorry, I should wait for you to call on me, Dr. Khan. Oh, wait.
Go ahead, please.
I think we should have two steps in this bill. I think we should be mandating that providers ensure that patients have access to their medical records. I think we should be mandating that. And I do think that we should be encouraging and supporting providers to become interoperable with each other for that to work. I understand that the state doesn't have the money, and we haven't had a lot of success with having central repositories. So I don't want language that makes that assumption. And so in that way, I'm just disagreeing with Commissioner Van Holling, the intent of this. But I do think there's a mandate piece of this that should be patients need access to their records. And that may be on a time frame of, up to 5 years. And then we should be encouraging, and maybe this isn't a VDR, programs inside the state, inside the HIT program that can encourage this interoperability between existing EHRs, because number one, the industry has changed a lot. EHRs are way more interoperable than they used to be. It used to be an HIE was the best solution because everything could go to one place because they weren't interoperable. Now it's much easier for them to become interoperable, and we should just be able to skip that, sending them to one river. They should just have all the rivers going. That's what I'm trying to push forward. So I would say mandate patient access to their medical records, support interoperability, and whatever we can come up with as a commission to support pushing interoperability forward, because the technology now exists.
So I think I agree with you, Commissioner Bond. This mandating part is very important. That's number one. And the interoperability, perhaps a time frame is given, perhaps even 5 years, to work towards that interoperable program where something would have evolved besides this private sector enterprise, and budgeting may have been taken into account over that period of time. But everybody would be on notice that within, for example, 5 years, that it would be expected or anticipated that we would have to have a universal interoperable program through their own EHRs. So I think mandating is a must. I'm a very strong proponent of mandating patient access to their medical records in whatever format they are provided. And I must commend UMC. You have this EPIC program, and that is an excellent program. I wish the VA had taken that program as it was recommended by the VA commission that I served on many years ago. But that program is accessible. All major institutions in the country have that program, and the patient with the click of a button can access his or her records wherever they go in the country and share it with the doctor. So, but that's for a future thing, but mandating is a must in my opinion. Any other comments?
Yes, Chair, we do have Vice Chair Commissioner Rubelip.
I'll let the other commissioners go. I'll wait. Thanks.
Okay, no problem. Commissioner Ralston? Oh,
Commissioner,
you're on mute.
you're muted.
Oh, sorry, thanks. So I just wanted to take a moment and just ask for kind of a point of clarification, or just take it a little bit step further with Commissioner Bond's request to mandating and Chair Khan's request to mandating the patient access rule portion. I think that is critically important, but I also think that just for clarifying purposes, I think that we need to make sure that the language specifically states that it's patients' access to electronic health records, or the EHR, because I just think in a real world example, I think patients already have access to our healthcare records, you know, HIPAA, and we're compliant, but patients might be given it in a different format, right? And so I might be going to one of my doctor's offices or a hospital visit, and I want my records, but they're not giving it to me in the electronic form in which, you know, the intent is for patients to have easier access to this data. So I just think as we're having this discussion, we need to make sure that that language is pretty clear. I can just see an unintended consequence, especially going through the legislative bill drafting process, in which a legislator or the bill drafter itself says that that's already available. So I think the really key is to make sure that patients access to their electronic health record. So, and if I'm off base, somebody correct me. I think that that is something that we need to make sure that we clarify.
Okay, any other commissioners?
Yes,
agree.
Chair. Additionally, we have Commissioner McAllister.
Thank you. So just for the record, and it might be helpful if commissioners would say if they're in favor or not favor before they speak, just so we get an idea of where we all stand. I am in favor of subject 3, topic 1 of approving that for one of our BDRs. And I just want to ditto what Commissioner Ralston just said. If any patient was listening to our conversation, I think they get very confused. They already have access to their medical records by federal law. We are talking specifically here about electronic records. So for families out in the state of Nevada, you already have protection to access your health records. We don't need to put that in state law to make that true.
Thank you, Commissioner. I also see Commissioner Rowadukin.
Thank you so much. Okay, so I am also in favor of subject 3, topic 1 moving forward. And I want to say that I agree with Commissioner Bond and Commissioner Ralston. I wanted to clarify the part of the access to the health records should be electronic, because like the commissioner before me said, patients already have access. It's just a little more cumbersome, and they have to do a lot more stuff or follow more steps in order to get those. And having access to electronic records via a patient portal or like a password, that would make it easier for a lot of the patients. And I agree with mandating the access, having that language in the BDR, mandating access for patients. That's all I wanted to say.
Thank you. Any other comments? Because then we may want to narrow down what language we really want in this BDR so that everybody can agree or modify.
Yes, Chair, we do have Commissioner Tyler Garner. Please go ahead.
Thank you. I really had a more of a procedural question or a clarifying question. Because these BDRs aren't listed in any order of prioritization, as we are going through each and all voting yes on them, will we get to an instance where we aren't able to narrow down it to 3 because we've said yes to everything? Is that a possibility?
Sorry, I didn't understand the question very well.
I guess at the heart of the question is we are having an extensive discussion about some cleanup language around a process or practice that already exists. And the process is supposed to be designed to identify, my understanding is the top 3 BDRs that we want to forward or submit, right?
Yes.
And so if we're going through them in this order, and it's no order of prioritization, and we're all voting yes to each of them, is it possible to get to the end of this list and have voted yes on all 5 and not be able to narrow it down to 3?
I think there may be difference of opinion in each subject by some commissioners. They may not necessarily concur with everything in every bill. And so I think everybody should have the opportunity to opine on them individually, just like we did for the first subject or topic. And now we're having a lot of discussion on the number 2 topic.
Okay, thank
So,
you.
modify and amend. So any other comments on this topic? So Melinda, the task falls onto you based on everybody's input, what language you can propose, and then we can hash it out to narrow it to specifics.
Thank you, Chair. Quickly, I did want to give Vice Chair Commissioner Rubelit a chance to discuss.
Just my last point, and then so I just want to point out that the way I see this is what we're trying to do is make sure that, as Dr. Khan described, providers are mandated to have systems similar to the way Epic functions, in that it's interoperable and easy to get access to records. I would hate for us to focus this on patients' access to their records, electronic or otherwise, because that already exists in federal statute, right? So I don't want us to get sidetracked. I think what we're trying to do is lay the foundation to be more interoperable without having to connect to an HIE necessarily. So hopefully that's helpful.
Thank you. Anybody else before Melinda tries to put everybody's thoughts together for the language? All right, Melinda.
Oh, thank you, Chair. Okay, so what I have gleaned from this extensive good conversation that we've had is to require providers to have electronic health records that are interoperable with a grace period, per se, timeframe of up to 5 years to implement those systems, to give patients more access to electronic medical records, and toward greater interoperability of patient electronic health records. Is that the consensus generally of this group?
So commissioners, you may chime in. Commissioner Van Holling is well known for his knowledge on this, and Commissioner Bond also had some suggestions like mandating part of it. So if I may request Commissioner Van Holling and Commissioner Bond to start the discussion. Either or unmute, please, if you would.
Commissioner Bond, please go ahead.
I agree that we need Commissioner Van Helling on this, but Melinda, I would propose that based on what you just summarized, we should be, and based on comments that others have made, we should be encouraging, and I'm okay with mandating, providers of healthcare to create interoperability in their health records over the next 5 years. I am okay with mandating, or I am okay with encouraging. I feel strongly that we are mandating patient access to their electronic medical records, because I don't think that may exist for Medicare and Medicaid, but it doesn't exist in the state of Nevada otherwise.
So if I may chime in before we go to Commissioner Van Holling, I like the idea. We still mandate patient having access to their medical records while encouraging the providers over a 5-year period to start participating in an interoperable program that provides the patients access to the records today. In whatever format, they have to have access to the medical records while the interoperability process works its way. Whether mandated or encouraged, I'm open to that. Commissioner Van Holling, are you back on? He was in Carson, and so there may be reception problems, he had told me.
Oh, no, Chair Khan, I'm here and was able to hear the summary, and I was comfortable with the summary piece of it. Again, I think just having an effective health information exchange, as long as patients are informed and consenting to opt in, and we can have a conversation about opt in, opt out. But I think the summary was well presented, and I think the direction that the commission was having a conversation with. But Again, I think we're heading in the right direction on custodial records within electronic health records. And I think the key word is interoperability. I think we left out where that repository is, whether it's with the current exchange or we want to look at something different. But I agree that we need time. We need a time frame to be able to do this. 5 years is good.
I'm sorry to butt in here. I think we need to make sure that Commissioner Van Holling, I think you're the only one that's considering this BDR right now as having a central repository. I think we're actually trying to do the opposite and allow it to be operating directly between physician groups without a central repository, but in guaranteeing patient access, whoever their provider is.
I certainly agree with that, Commissioner Bond. That I think it's kind of twofold, but first and foremost, having access for patients within their electronic health record in the state of Nevada is extremely important. And then if the commission continues to want to have interoperability, which really means a hub for sharing of information, I think is going to be critical for having an effective system. So that's just my position, but certainly agree with the first point of patient access is the most important. And having that, and again, the current exchange that we have, it does allow for that. It's just not as mandated to feed that information. And again, we can talk about is it effective or not, but certainly agree with patients having access to their information through a portal of electronic record keeping.
Thank you, Commissioner Van Holling. Does anybody else have a different opinion than the gist of what Commissioner Bond and Commissioner Van Holling just mentioned? My only question is, I agree with everything that was said, whether the word should be used as encouraging for 5 years or mandating in 5 years. That's my only question. And what is the appetite of the commissioners?
Commissioner Bond? Oh, sorry. Commissioner Ralston? You're on mute.
Sorry, I know I'm on mute. Thank you. I actually I really appreciate the robust discussion, and I think that we're saying a lot. I would actually just try to move forward with making a motion to vote on this being one of our potential or one of our 3 BDR requests, following the summary that you stated, Melinda, earlier, in that it's mandating that all providers of healthcare implement an interoperable healthcare electronic system, and mandating that patients have access to their electronic health records.
All right. There's a motion on the floor. Is there a second to this motion? Do I hear a second?
I'll second it,
Okay.
Commissioner McAllister.
Any further discussion? Otherwise, we can take a poll. If none, then all those in favor of this language as proposed by Commissioner Ralston. All those in favor, please raise your hands.
Okay, just checking. Okay, and I do see all commissioners' hands are raised.
All right, thank you. So the motion carries. I think we are coming along very well, given the complexity of all this language. We have done very well overall. So now coming to the next potential 3 BDRs. There's a number 3, number 4, and number 5 based on the priorities of the various commissioners that we have talked about. Melinda, you want to pick it up from here, perhaps? The item number 3 that was in the sequence of priorities. If we can read out that and see where we go, because we have an option for 3 BDRs.
Absolutely. Thank you, Chair. And I just want to note that all 3 of these topics did receive the same number of responses. So they are all of equal weight in their
Good to know.
Presentation here. Okay, so now moving into the next phase of this agenda item, we're going to be discussing the remaining top 3 BDR topics. As a reminder, I will again give an overview of any new information provided for each topic and ask for discussion. And then after discussing all 3 remaining topics, Chair Khan may call for a motion. So first we'll move into subject 1, topic 1. Subject 1, topic 1 is both summarized and clarified that this potential BDR topic is requesting a study be done by an experienced vendor to determine different strategies and design decisions for a health insurance program for infants, children, and young adults up to age 26 who are ineligible for full Medicaid coverage under federal law due to their current residency or immigration status, to outline coverage options that are primarily state funded. This topic is requesting both the study and the funding to support the study. This BDR topic is not proposing a health insurance program for this population. As requested during the July meeting, I've received the following added information regarding this topic. The Division of Healthcare Financing and Policy, or DHCFP, notes in the description that this should be described as a state-funded healthcare benefit because Medicaid dollars are not available for this population, so it would not necessarily be a Medicaid benefit. Medicaid funding could be used as it is today to pay for emergency Medicaid only services for this population. DHCFP would be happy to provide information and assist with the study as needed. In response to the question posed to state agencies, are you currently carrying out an activity that provides basic health care coverage to infants, children, and young adults up to age 26 who are ineligible for full Medicaid coverage due to their current residency or immigration status? The Silver State Health Insurance Exchange notes that they are not currently carrying out any activity or having initiatives to offer a basic health program on the exchange, and there are no seen consequences just for studying this option. But it should be noted that if the program is implemented, and depending on federal poverty levels that the basic healthcare coverage would apply to, there could be consequences to ACA qualified health plans currently sold on the exchange in terms of reduced enrollment due to competition. Otherwise, there were no added state agency comments to this posed question. Additionally, the Deputy Attorney General had questioned if the PPC has the funds designated to hire the expert, and further commented that unless the PPC will be trying to amend a statute to allow the PPC to hire the vendor, use the funds, etc., that the PPC could hire the vendor without a BDR. And to these comments, I just wanted to clarify that while the PPC could hire the vendor without a BDR, because we do have that in our statutory authority, the PPC does not currently have the funding to hire the expert. The BDR is needed to allow and provide for the funding of this study. The DHHS PPC could be the responsible agency charged to complete the study, in which case the DHHS PPC would assign a fiscal note of up to $200,000 as is noted in this proposed BDR topic. I would now like to open this BDR topic up for discussion. And please go ahead and raise your hand if you have any comments.
Yeah.
Commissioner McAllister, please go ahead.
As I originally proposed this, I feel like I should say something. I think Dr. Kaporo, who's the medical director of Medicaid, summed it up best when she spoke to our commission last month that this would be game changing. And so this, for the record, is my choice for our third BDR.
Thank you, Commissioner. I also see Commissioner Winkler.
Oh, thank you. And this is something, this topic area is something that I supported. I am just concerned that if we're requesting like a study be done, I'd want something more concrete. And especially if we're limited in what we can request, I'd want to make sure we're doing things that can really deliver something to patients. That's kind of my main concern with this one.
Anybody else?
Commissioner Tyler Garner.
Good morning. I just want to note that I strongly support any effort that would ensure healthcare access for as many Nevadans as possible, particularly our children. Recognizing some of the constraints noted today, are there other paths forward or ways in which we might make progress by amending what is proposed here.
Sorry, I understand proposed language needs to be modified is what you are suggesting?
I'm suggesting that given the constraints noted about the budgetary constraints as well as the flexibilities or opportunity, because we wouldn't necessarily need a BDR, with a commitment to ensuring healthcare access for children or as many Nevadans as possible. Is there some modification to this language that would allow us to make progress there?
So if I may quickly respond, the way I look at this BDR, it has a major fiscal impact. As has been alluded to earlier, this comes under state budgeting. The state has to provide the funding and resources. If a committee is created to give their recommendation, budget impact will be very significant and dramatic. And the last thing we need is propose something that falls apart because of the sheer magnitude of the proposal. In the legislature, funding, as you know, is always a challenge in the budget debate. So I would suggest we all keep that in mind. It's nice to have a committee do the study, but there are examples in other states that this does cost a lot, and the state is willing to increase taxes on people to create that resource.
Thank you, Chair. I do know we have a couple of other commissioners with their hands raised. Commissioner Ralston, please go ahead. Apologies. Oh, I think you are muted.
I'm so sorry. I have not had enough coffee this morning. I just want to say that it's a little bit difficult having this discussion for the remaining three. I think they all warrant support and attention. And I think that this is not a priority one of my three for this discussion, but in no way does it represent my not supporting this effort. It's really more about the legislative process and seeing this one and also the drug affordability BDR. Both will carry a huge fiscal note in my opinion on the state. So what I would like to propose is having a discussion with this commission about supporting these three efforts, maybe taking a vote on the three so we know how to narrow it down, but also directing the executive director to draft up a letter specifically to the legislature. And I think you are in your most recent note about to propose are about to present to the Legislative Commission on Healthcare. And I think that you should draft a letter supporting the other two efforts, whichever one doesn't go through, and have the full weight of the commission supporting these efforts, just knowing that for me, the two with the largest fiscal note faces a lot of hurdles, but really asking the legislature to consider these, and maybe a legislator will have the ability to pick it up and dive a little bit deeper than we have the capacity to do so. And look into it. So I just want to throw it out there as we're having this. It's really hard to have a vote on something, especially when we're talking about children and young adults. I just know that it's harder to move forward a legislative proposal with a large fiscal impact.
Thank you. Any other comments?
Yes, I do see Commissioner Winkler.
I've spoken. If I could give my time to a commissioner who hasn't had a chance.
Commissioner Bond.
I think that I'm understanding what Commissioner Ralston is saying, and also what I believe Commissioner Tyler Garner is asking, which is there a way on this topic, which I think is a global topic, it's kind of like a canopy topic with a lot of pieces, and if we can't support it in this commission as its own BDR because of the fiscal note, we're just afraid it would hit a buzzsaw in the legislature. At least that's my concern. Is there a way for us as a commission to to have Melinda both present at Interim Health the importance of this topic to us, and to have a letter from the PPC go to the entire legislature about our support for investing in this? And is it possible that we could do a a resolution instead of a BDR. That would, instead of a bill, you can do legislative resolutions and have the legislature in both houses support the resolution so that we can move forward on the PPC focusing on this in the future. Is there anyone on the phone that could say, tell me if this could be a resolution?
Is DAG on the line?
Suzanne, do you have the ability to opine on this topic, please?
As to whether something can be a resolution?
Yeah, instead of a bill draft, there's a legislative resolution process that is not a statutory request. It creates intention and direction and support from the legislature without legislation.
And I am not familiar with the resolution process. What I can tell you is if you're looking to make a statutory change, it's my understanding that needs to be done through the BDR process.
Right.
And as far as the resolution process, that is probably more of a question for LCB as opposed to my office.
So can we as a commission send a letter suggesting that the legislature look at this this whole issue and address this issue in their own capacity as a legislature that goes. So we would have made a quote recommendation rather than a BDR. Is that doable?
I believe that can be done unless it's prohibited in statute or in the bylaws, which I'm not aware that it is. But I think that probably could be done. I have no idea how it would be received by the legislature or how effective that would be.
Well, we would have comment given the budgetary challenges that Commissioner Olson also alluded to, and it's my concern. At least we would have been on the record supporting this consideration. And then it's up to the legislature if they're willing to find the budget or just table it for future reference. We would have done our job and passed on our opinion or consensus.
That I think that is something that could be done. The commission would need to agendize doing the letter, assign the letter, and then approve the letter.
All right.
And then submit the letter and then lobby the legislature to pass a resolution about it.
Yeah, I like that part. That's my thought process also. Any comments from commissioners for us to send a recommendation or suggestion in a letter form, and then like Commissioner Bond alluded to, then we can tell the legislative people individually or otherwise that please seriously look at this.
I see Commissioner Winkler.
Hello, thank you. So I do support putting the commission's support on this topic, but specifically if the first step is conducting this study to understand the return on investment, so that way we have that information to build a better case and argument for this. Is it possible for the PPC to request the funding to do that study separate and apart from a BDR? I know there's the American Rescue Plan Act funding available for all kinds of different programs and services. Is there a way to do that? And that way we can have that study performed, PPC can look over that data and be able to give a really informed BDR showing these are the ways to address this. This is how we can start covering these kids. Is that possible?
Just a quickly comment, does also following up to your comment, does it prevent the legislature to create their own committee or expert team and budget it for them directly and have the study done? This is for the DAG, I think. Can we test that?
I don't know of anything that would prevent the legislature from doing that. I'm also not aware of any specific authority for that. that's not really a legal issue.
So we could request that the legislature set up a committee to study the fiscal impact, etc. And then it's up to them what they do with it.
Right. Like I said, unless there's a prohibition in statute or our bylaws, and I'm not aware of any such prohibition. So I think that the PPC could do that.
All right. Any other comments from commissioners to doing that in the letter or thoughts?
I see Commissioner Roa Dugan. Please go ahead.
Thank you. I wanted to say that I support Commissioner Winkler's idea. I think the BDR here is asking to do the study, not to create the program. So if we all think that the study has a fiscal note that is too high and possibly be denied by the legislature, maybe we can find funds otherwise without creating a BDR. If that is possible. If that is not possible, I would like to move forward with this BDR in order to get the funds through the legislature. This is a very strong topic for me that I support very greatly. And if we can do the letter to the legislature for this subject, that means we could do that for the other, like the prescription board. And the other, if there are other topics that have a fiscal note. But I support this topic, either going forward with the BDR to get the funding for the study or trying to get the funding in a different way without the BDR.
Okay. Any other comments?
Yes, Commissioner Ralston.
Sorry, I also just want to weigh in and say that in the letter that you write and you draft to the legislature in support of this or any other BDR, I agree with what the other commissioner said, and ditto Commissioner Winkler's request on looking at seeing if you have any options to procure a vendor to look at the analysis. And I can say that I am aware that the executive director has the statutory authority to contract with an outside vendor to use funds. I know that it's very, very limited in the amount of resources that the PPC does have, but she does have the statutory authority to contract for this outside of a BDR. Doesn't mean that she has the funds, but she does have the ability to. So I do think that that is a path forward and an option, and maybe that's something that the commission can come back and discuss when we have more information on what the cost barriers are and what the other options are should this not go through the legislative process.
So now down our discussion, if I may, should we get some consensus or otherwise on number one, should we be sending a letter to this effect to the legislature as has been proposed with the language recommendations, or as a BDR? It seems to me, listening to everybody, the BDR is not necessarily the best way of going about because of the fiscal impact, but a letter would be at least appropriate at this time. Is that the general feeling of the commissioners? Any comments?
Chair Khan, I think that makes sense to ask whether or not we think this needs to be a BDR before we continue the discussion.
Okay.
We have several other avenues to get the money to the PPC.
Okay, I think we take it in two parts. Number one, poll our commissioners whether they are in support of presenting this as a BDR, and then we can come back. If not a BDR, should we do a letter? And if it's just for the BDR, then letter becomes a moot point. So should we take a poll, Melinda, of the commissioners who want this to be sent in as a BDR?
Sure, I can absolutely do that. So all commissioners in favor of submitting this topic, subject one, topic one, as a BDR to the legislature, please raise your hand.
Melinda, I'm sorry, I just need clarification and before you do that, or as you're doing that. So if we say yes to this, then we wouldn't say yes to the other two that are remaining. We're having to make a vote right now on which of the final three we support, and we can only really support one. Is that right? Because if we all vote, to Tiffany's point, if we all vote for all three, we don't have a solution.
Yeah, I move that we table voting until we've heard about all three, and then we each have to pick one.
I think this vote though was maybe to take this one off the BDR list because we
Yeah,
have
so I don't support that.
Right, that's what my proposal is, to take a vote on whether we should take this off the BDR list. Then the second poll would be, then if not the BDR, should it be in the form of a letter that we have debated earlier? We can go to that and then move to the other two individual proposals of BDRs. So
This is Yarleni for the record, Commissioner Rodriguez. I would not be able to vote on removing this topic from the BDR list, possible BDR, until I know that we do have access to other kinds of funds. So I think that we should wait in order to vote for the last BDR until we have that information.
Any other comments?
I would like to return to my original comment, which is Medicaid showed up in force at our last meeting in support of this. And I think that's meaningful.
Right, so I think the simplest thing is to get a vote of the commissioners, how many are in favor of this, and those who have reservations may vote against it, obviously, so that we can move forward in our discussion.
This is Commissioner Winkler. I don't think it costs us anything just to review the other topics before we start taking them out. We can just review them and then vote on once we've heard the other two.
Any other comments from commissioners?
I agree with Commissioner Winkler.
Because we'll be coming, if we do all the three, in my opinion, then we'll come back and start redebating each one of them all over again to select between the three. If we go one at a time, we made a decision on one, whatever that decision is. We make a decision on two, whatever it is, and make a decision on three, whatever it is. And in the end, if we are opposed to all three, then it's opposed to all three. And if we are in favor of one out of three, we are in favor of one out of three. That'll make it more efficient and more specific rather than duplicating our debate and discussion given the time constraints also. Because I guarantee you people would want more input after we've discussed all three. We'll start discussing 1, 2, and 3 all over again.
Chair Khan, if I may, I do see comments from a couple of commissioners. Vice Chair Commissioner Rubelid, please go ahead.
I just wanted to point out that there are several avenues to get funding for a study, right? So we could either put it as an item for special consideration in the PPC's budget. That's one option. We could write a letter, or we could ask for American Rescue Plan funding. None of those are guarantees, but if we don't require a BDR to do that's my only point is, I support this wholeheartedly, but if we don't need to use a BDR to do it, that frees us up to do other things. And so that's really what my recommendation would be, is that we pursue all of those other avenues rather than use one of our BDRs.
And sorry, I don't mean to jump ahead, but that is exactly what I had intended when I first spoke up, that's exactly it, that I'm not sure that this request really warrants a bill draft request, that there are avenues to move forward with this request, just not through the legislative process.
That happens to be my view also. We could save this, if this could be accomplished in other ways, we could save a BDR out of the remaining two then, if we have to. So I think we should proceed with the polling of the commissioners. Those who want to present this as a BDR can raise their hands, and then depending on what the response is, then we can move on. By default, I would imagine then the second option would be to send a letter. So if you could proceed, please, Melinda.
Chair, really quickly, I do notice Commissioner Bond has her hand raised.
Yeah, Chair Khan, would you consider this as a different way to approach this? Would you consider this? Could we just listen to all three of the BDRs? We've gotten through one. Let's listen to the second one. Let's listen to the third one, then come back and without further, rehashing these BDRs, vote. And everybody votes on one of the three. And then whichever two didn't make it, we could talk about what are the steps that we can go through to make sure these BDRs are addressed by the Patient Protection Commission without a BDR, because in a couple of cases, I think there are other routes, but I completely understand what Commissioner Rodugan is saying, is she doesn't want to hand over the BDR option if it's got the most votes, and we need to go through that process. But I agree with you too, that we shouldn't keep debating every one of these. So if you go through all three, then go back and vote, then talk about follow-up.
I think if everybody agrees and promises not to rehash the discussion when we come back to them, then I have no problem doing this, because I think time is important. We don't want to table things for the next meeting. So I think we are okay. I'm okay with that. So we can proceed that. We can move to item number 2 and start discussion on that, and then to 3 and discussion on that. Then we can decide just by a simple vote which one people want to vote for in what format. So that's my position. So let's proceed, Melinda, to the item number 2.
Sounds good, Chair. All right, so subject to topic 3 is a potential BDR to address the rising costs created by healthcare market consolidation by prohibiting hospitals and possibly some other facilities such as freestanding emergency rooms from hiring physicians. Revise the exemptions now in law to ensure only community hospitals and academic institutions are exempted. As was requested during the July meeting, I've received the following added information regarding this topic. In response to the question posed to state agencies, if the state of Nevada were to implement a law clarifying the prohibition on the corporate practice of medicine, are there consequences to any of the other programs you currently administer? The Division of Public and Behavioral Health, Bureau of Healthcare Quality and Compliance, or HCQC, reported that if the BDR is written, so this is required in NRS Chapter 449 under private hospitals, then enforcement would fall under HCQC's current NRS Chapter 449 process. If the BDR simply notes that a hospital cannot directly employ a physician and only enter into a contract with the physician, then there is no estimated fiscal impact to HCQC because they would be flexible to incorporate into regular survey workload in a manner that does not significantly increase work hours. On the other hand, if the BDR specifies how this is to be carried out, then yes, there may be a fiscal impact because HCQC may need to hire staff to carry out any additional work duties. For the public hospitals, that is Chapter 450, HCQC also licenses these hospitals in accordance to NRS Chapter 449. So would assume a change in NRS 449 will be sufficient, but again, LCB would determine. Adding further or new duties or processes creates extra work, which may result in fiscal impact of up to $90,000 annually for up to 1 full-time equivalent staff. Additionally, the Division of Public and Behavioral Health notes that an exception may also be sought for the state hospitals, as they employ mostly contractors, but do have some state FTE physicians. Otherwise, there were no added state agency comments to this posed question. The DAG had also confirmed with regard to this topic when asked if there were components in which may be carried out without a BDR, that any modification to existing law and Nevada revised statutes must be done through the BDR process. Although no specific statutes are mentioned in this topic, modifying existing law would most likely involve changes to NRS Chapter 449 and possibly NRS Chapter 630. Additionally, I wanted to give Commissioner Bond the opportunity to present any added information on this topic prior to the PPC discussion. Commissioner Bond, please go ahead.
I appreciate that. And there were some questions last time about how would this, what are some of the consequences that might happen from trying to create a very clear clarification that hospitals should not be allowed to hire physicians. They should contract with physicians. And I think that one of the notes that I remember coming up is Commissioner McAllister, you had a concern about how does this impact the rest of the state of Nevada, other entities that hire doctors. So I went back and I did have LCB answer a very quick question. I'm not a legislator, so I'm very unempowered in asking for LCB clarifications. Melinda, I think you could get a little farther if we still have this concern. But as directed by LCB, those entities are already specifically allowed in statute to hire doctors. It's under the DOI, and our DOI commissioner might be able to weigh in on that. It's under NRS 695B. But I'm not an attorney, so other sections as well. So specifically to that question, I think that's already been addressed in statute. I think what's happening in this one is we're just trying to very clearly delineate that this is not allowed in a hospital to hire a doctor, contract with them, as has been the tradition. And the exception to that would be, I would say, public hospitals or public entities, not private entities, because that would address the academic issue and the state employee issue and the county hospital issue. So that's what I would propose to change this BDR to, or clarify in the writing of it. So that's it. I think the only other thing that would be for me to remind us why we want this in statute, and it's because we are so low on staff, that professional staff, physicians, that it's really easy for one entity, if they're allowed to hire them, to tie up the entire specialty for the entire county, because they're not available for the rest of the county. And I think that's a real problem.
Okay, is Commissioner Van Houweling on the line?
I am Chair Khan, yes.
Could you kindly comment from your perspective?
No, I think the additional research and looking at the current existing laws that that need to be enforced, but also some of the clarification that we've had, I think suffices to ensure that we have a balance. And I think the key is, allowing hospitals that have academic and public missions are able to fulfill that, but also ensuring, as Commissioner Bond mentioned, that private hospitals should contract, not employ physicians. I think definitely brings balance. So I agree with some of the changes on some of the other NRS that may need to happen, but I think this is important under the access PPC goal to ensuring patients have access to specialists in particular.
Okay, my quick comment is, as far as I know, just about every hospital, at least in the southern state, and also in North, where this one bigger hospital is renowned there. But every hospital system has GME approved slots, and there are residents and student training at every hospital. Every single major hospital system is involved in the academics in some of the key areas of residencies, whether it's emergency room medicine, trauma training programs, neurology training programs, psychiatry training programs, where the residents are working in multiple specialties in just about every hospital. So does that put them also into the academic? Additionally, what Commissioner Van Houweling says, the contractor is one aspect of it, because you cannot find people teaching residents, whether it's private hospital or otherwise, without being compensated. And correct me if I'm wrong, Commissioner Van Houweling, UNLV potentially is paying for them, but UMC is also contributing towards that cost of academia.
That's correct, sir. Chair Khan, there is an affiliation agreement via the two public institutions, and I think that's where it allows us to have that relationship, whether UNR or UNLV is teaching into a public institution, and I think that protects the academic missions of those and those residency programs, but still the fundamental core that this is a public institution versus a private institution. And most of those hospitals that you refer to have a contractual relationship. And I think that's the key is not an employment contractual relationship, but a provider service agreement or an academic contract to be able to do that teaching, but still not allowing for employment and circumventing the corporate practice of medicine that, again, for every commissioner that's on this commission, we do have laws that are in place. They're just not being enforced as well as they should. So tightening this up will allow for insurance that all patients have access to specialists, especially in our rural and our smaller communities where there's limited resources.
Any other commissioner want to comment?
Yes, I see Commissioner Ralston.
Hi, thank you. I got my mute off early. So I just want to throw this out there that this is actually the BDR that I do support. Again, the other two, I think, warrant our support, full support, but given the fiscal note on those, this one takes a higher priority for me. It also takes a higher priority for me because I really believe on the patient side, how this will benefit the patient. It really complements the work that this commission already started with the cost growth benchmark. And based on the reports that we've already seen through this program and through Baylor Health, Nevada's wage growth grew from 18 to 19 to 2.4%, but the commercial trend in healthcare spending was 9.2%. Those are the stats that we have. And so you could see that the spending, healthcare spending is growing at a far higher rate than our median wage growth. I think that's a problem. That's a problem for average households in Nevada. It's a problem for patients, and it directly relates to price. What I think that this does is this is also ways that the state needs to look at is ways to how do we mitigate spending growth, and this directly addresses prices because based on the information that we have seen, prices have grown a lot faster in Nevada, and I think that it's an indication of hospital market power. And we need a way that have driven the prices up, and our wages haven't followed that. So I also see this as a huge benefit, an indirect benefit to mitigate spending growth in our state, and I fully support it. And I think that the patients will benefit from this as well. So I just want to throw that out there, and that this is the one that I do support for those reasons. Thanks.
Any other comments?
Yes, Commissioner Bond.
I just wanted to follow up with what you said, Dr. Khan, 100%, and what Dr. Van Halen said, 100%. We want to make sure the public entities, the academic medical centers, the academic institutions, the GME program, which is federally funded, is not going to be disrupted by this. So we need that carve out to make sure that's clear in the language. But we do need something in statute to prohibit private hospitals from hiring doctors. And I do think that does not in any way disrupt the contracting process that exists between any facility and a doctor, which is something you asked about a couple of times. For sure, this bill will not impact contracting. It will actually encourage it.
Thank you. Any other comments?
Seeing none, Chair.
Okay, my only one other comments on this is I think we need to be cognizant of the fact, since it keeps coming up for the last 30 years in every forum or board or commissions created by various governors. I happen to be on one of them many years ago, is the patient access because of shortage of physicians. And as I may have mentioned before, Governor Gwynn had summoned a task force, and we were at the bottom then, and not much has changed in patient access programs. The biggest impact is, of course, in primary care, but there's even a significant impact on tertiary level of care, which has ended up requiring some of the hospitals to recruit physicians that they could not otherwise recruit under the J1 visa program as underserved. For example, correct me if I'm wrong, Commissioner Van Holling, at UMC, there has been challenges of finding good neonatologists, and we had to, and I was on a committee at that time, and I had gone along with that, is that they have to have exceptions under visa programs because you can't find tertiary level care of physicians. So there is a dearth of tertiary level physicians also, and they're being addressed on a case-by-case basis as time has gone along. So I think just be aware that we have to be cognizant that whatever we decide does not impact the access of patients to care, since we are at the bottom of the list in every category: primary, tertiary, secondary, specialties, etc.
Commissioner Winkler, you have your hand raised.
Hello, thank you. Yes, and I wanted to add to this point and on this topic that we want to guarantee that healthcare providers aren't stuck at a specific facility, that patients have access to them. There's not non-compete clauses that prevent them from working in an area, or specifically they can only work in one facility. I think that is the strongest way to address that access issue, as well as challenge market consolidation by these big forces that can raise the prices if they control who has access to that specialist or that service. Thank you.
Thank you. Any other comments on this subject?
Seeing no further comments, Chair.
So we'll move to item number 3 then.
Will do. All right, so subject to topic 6 has been modified per Commissioner Winkler based on discussions during the July meeting. This potential BDR now reads, create a prescription drug affordability board, expand on NRS 439B 630 and set allowable rates for certain high-cost drugs identified by the board. As requested during the July meeting, I've received the following added information regarding this topic. In response to the question posed to state agencies, if the state of Nevada were to implement a law establishing a prescription drug affordability board, are there consequences to any of the other programs you currently administer? The Aging and Disability Services Division reported that they have submitted a BDR to create flexibility within their senior and disability prescription drug program, which does not address any of the system issues related to prescription costs. However, the board being proposed by this topic could be helpful to the senior and disability prescription drug program in helping direct this program and how to best meet the needs, as the division has no clinical staff to provide this type of direction. PEB, the Public Employees Benefits Program, has also reported that they continuously consider several different programs aimed at curbing the cost of prescription drugs. One concern noted with capping the cost of drugs for members is that the cost will ultimately be borne on the health plan. In the case of PEB and other health plans, the total cost gets spread among all members and eventually becomes part of the overall cost of the plan. In other words, the cost gets passed on to the member in the long run in the form of higher premiums. Secondarily, the detailed BDR document provides an example from another state, Colorado, implementing a prescription drug affordability board, noting estimated fiscal impacts to state expenditures by about $800,000 plus 5 full-time equivalents in year 1 and $500,000 plus 4 full-time equivalents in subsequent years. Otherwise, there were no added state agency comments to this posed question. And lastly, the DAG confirms that if the Prescription Drug Affordability Board's creation is to be codified in statute, a BDR would be necessary. However, if that board would be a subcommittee of the PPC, a BDR would not be needed. Additionally, I wanted to give Commissioner Winkler the opportunity to present any additional information on this topic prior to the PPC discussion. Commissioner Winkler?
Thank you. So, as I was considering these BDRs, I took in mind kind of 4 guiding principles based on our statutory charges, and that is improving affordability, availability, health equity, and health outcomes for Nevadans. And I believe, well, I'll start first, like why remove the requiring a health plan review board? I think it'd be another big lift. And it might involve a greater discussion about making authorizations for review for the Division of Insurance. And I don't think we have enough time to really get into that. But what I was mostly concerned with is with everything that we're doing, I want to make sure that if we are controlling costs, we pass that on to consumers, that their out-of-pocket costs also go down. And so I'm happy to hear that we'll be able to work with the LCB in the drafting codification of the benchmarks so we can ensure not only that we track primary care, but also we look at affordability. What do those out-of-pocket costs look like as well? So with that in mind, that's why we removed that portion. Otherwise, I think this is something very directly connected to the work we're doing with the benchmark, as well as some of earlier transparency measures that the legislature has pursued. It's unfortunate that Ms. Laura Rich is not here because I feel like her comment didn't really address what a affordability review board would do. That instead it would set upper limits for the entire statewide, of what could the state and all our purchasers afford to be able to pay for a drug, so that it's working with the manufacturers and, you know, finding what's the least amount that we can all pay for these drugs. There's lots of other states that have done this and seen great results from it. I think, well, yes, I'll just leave it up for discussion. I think it's kind of, that's where we stand on that.
Thank you. If I may just start off on this, because this is a subject very, very dear to my heart. And why it is dear to my heart, I've been very fortunate and privileged to afford co-pays, deductibles, and the price, even for vaccines like Shingrix, my co-pay, etc., was $450. Seniors cannot afford it. People cannot afford, and these co-pays and all are high because managed care ends up paying an arm and a leg to the pharma to obtain these medications through intermediaries, etc., etc. It is in my mind and my view crucial that we have some way of controlling these high-cost essential drugs, and insulin comes to mind. We still don't have a valid, strong restriction on essential drugs, and the federal government has not been able to pass it yet, as I recall on the recent discussions. So I think it is crucial that something needs to be done, like yesterday, to take some of the burden off of the common man who cannot afford $250 a month or $300 a month in payment towards the drugs. And the pharmaceutical companies log on costs like they're unbelievable, even for generic drugs. I mean, generics are supposed to be cheaper, and they tag on prices to that also. So to me, this particular BDR, whether it's the board or further restricted cost issues on essential drugs, that the pharmacy company do not pass it on to the managed care either, but take it off of the cost of the patients, is crucial to me. Pharmaceutical company may not like it, but it is what it is. We are the highest paying pharmaceutical drugs in the world. Totally unacceptable. We all know the stories of people going to Canada and getting drugs and medicine. Same company, same brand, not even generic. I've been a beneficiary of that. I happened to test myself in another country, neighboring country, and I got that same drug for pennies from the brand name. And I came back here, the same thing in generic was 5 times more. I'm just singing to the choir, I hope, but this has been discussed at length at federal government, and pharmaceutical companies are very effective there. And something has to be done, at least at the state level. I've said enough. I'll let everybody else chime in. Comments from commissioners?
Commissioner Bond?
I really appreciate this BDR topic. I believe that we do need some group in Nevada that's totally focused on prescription drug affordability. We do it a lot in the legislature, and the state of Nevada has done a lot with transparency, and the state's pharmaceutical team has done a lot to lift the transparency laws up into some visibility, but it needs ongoing work and it needs accountability regularly. And because we have so little control over what can happen with federal prices, because of the way that the corporate practice of medicine is set up, and because of the way, I'm sorry, I'm mixing up my topics here, the way that interstate commerce is set up for pharmaceutical industry, and also the way that patent laws are set up, it's really hard to find a secret sauce to make a change, and it needs a lot of attention to do that. So I really support the idea of this. I think I'm stuck between these two of these BDRs as the ones moving forward, but I would like us to also explore all the ways that this BDR could stay alive if it's not a BDR. And I wonder if we could use a subcommittee, create a subcommittee under the PPC to both work through this issue and try to appoint a drug affordability group that's a subcommittee, similar to what you've done with the advisory group, or maybe it morphs into the advisory group. But I understand that you want a stakeholder group too, so I take that back, Melinda. I know that you're very interested in making sure the stakeholders have a seat, so I'm not trying to replace that. But I do think we need some really dedicated work on this. And I'm just trying to think about how we get more done. Also, I wouldn't want to suggest that if it's not okay with Commissioner Winkler.
Any other comments?
Good morning. I would just note I'm supportive of that recommendation. Think that this is a critical issue, particularly for us as an entity, recognizing that we've received data about pharmacy costs being a significant challenge in our system and our role. And so where there are opportunities to identify viable pathways to make progress in some of these key areas, I'm very supportive of the alternatives. And so just want to echo the importance and value of it, and to note that we've received data specifically talking about the challenges around pharmacy costs as an entity. So hope that we'll give some consideration to how we might support this effort, including in a subcommittee or some other pathways.
Yes.
Sorry, Commissioner Vice Chair Rubelid, please go ahead.
Thanks, Melinda. I would just be curious as to the authority to, I wouldn't want to create a subcommittee that doesn't have authority, right? So the PPC doesn't necessarily have the authority to set allowable rates, right? So we would have to either change the PPC's authority. That's my only concern. I think it's a great place to put it. I just don't know how much authority we have in current statute to set rates. I think we can only make recommendations. And so that's just all I would say about that. But
Any other comments?
Not seeing any, Chair.
So just a closing comment, I've said enough already. Drug Affordability Board will have some budget impact, obviously, and we need some input on what the budget impact would be. This was in my mind, very important. I see people suffering every day because they can't afford these drugs. And if the federal government is moving at snail's pace, perhaps the state can at least get started somewhere and get in some direction. The sooner, the better. But we need the answer of budgetary impact also, like we were discussing in one of the other BDRs.
Sure. So Chair, I did just want to clarify, there was that example provided by Colorado that did have the budgetary impact estimated at 800,000 plus 5 staff for 1 year, and then 500,000 plus 4 staff for subsequent years.
That's a sort of a starter. It may be different here in Nevada, but at least one knows what it is like. And hopefully the legislature will look into it.
Thank you. And then we do have some additional comments, Chair. So Commissioner Tyler Garner, please go ahead.
Thank you. I just want to note, I also believe the topic of prescription pricing transparency was a topic of interest at a recent interim Health and Human Services Committee convening, where a study was proposed in support of some Senate bill legislation. And so there may be some opportunities to coalesce around that issue in that way and be open to what the possibilities are. So knowing more, one, about their aim or focus, two, whether or not the study, where the study is, and if there is some synergy there for us.
Thank you. And then Commissioner Bond.
I'm just responding to Commissioner Rubelid's concern about statutory authority. And I wonder, we're getting a ton of data from the growth benchmarks if everything happens, as well as the all-payer claims database, as well as federal law. I think we'll have data. And so I think if we create a subcommittee, I know we have the ability to create subcommittees in the PPC. I think we can create up to 5, but I don't think that they could set allowable rates. They could recommend them, though. They could put together the work needed and the research needed to then move forward with that at the time that we have the next opportunity for statutory authority. But I believe that that would be a good home for this work. And I just wanted to highlight that again, I guess. Thank you.
Thank you. Any other commissioners?
Yes, Commissioner Winkler.
Oh, thank you. I just thought maybe perhaps since we have the subject matter experts here, if Baylor Health would be able to comment on if the comparison from Colorado would be, would that apply to Nevada? Could the PPC take on some of this work as a subcommittee? What their thoughts on that would be?
So this is Dr. Khan here. So as Commissioner Bond pointed out, if we do create a subcommittee, then the commission doesn't have the authority to make any impact except make recommendations again back to the legislature in this whole context. I am personally very strongly for some kind of an oversight board to give us data through transparency mechanisms and put together, as we have put it in quotes here, allowable rates. So at least we get started, the sooner the better, because the way I look at it is we may set up a committee and I have no problem with that. But by the time the committee comes up with proposal, et cetera, this legislative session would have gone. And then we would have been to the next one. If we are able, and if everybody agrees on, if we have a BDR option, then the legislature would at least have to discuss it, debate it. They may agree with us or not agree with us, given the fiscal impact. But if they hopefully agree with it, that'll have immediate impact, just a deterrent on the providers of pharmaceutical drugs, especially the not so expensive one also. So that is my view on this subject.
Thank you, Chair. I'd like to invite Michael Baylett to opine.
Yeah, so I agree with the chair's opinion. I don't think that this would work as a committee. I think this is going to have to be staffed. There's a fair amount of work to do this, which is why Colorado has the budget they do. As to the adequacy of their budget, I can't speak to that. But I know that other states that have created prescription drug affordability boards have dedicated staff who are assigned to the review of drugs and the assessment of where a rate should be set.
Thank you. Anybody else?
Not seeing any, Chair.
So that should close the discussion on this topic. So now, as we agreed upon, without additional discussions, maybe we need to poll on these three topics as to where the commission stands for the next BDR proposal. So should we start the process, Melinda?
Yes, absolutely. So we talked through a few different options for these three remaining BDRs. One of those options being that we decide on one of the topics, and then the other two topics we will create a letter to the legislature and have it approved and signed by the PPC as a strong recommendation to the legislature for those two additional items. So with that being said, is there a motion to move forward with one of these topics as the third BDR for the PPC? And really quickly, I do want to note Commissioner Vice Chair Rubelid, please go ahead.
I would just like to make a motion on subject one, topic one, to put an item for special consideration in the PPC's budget to fund the study and remove it from the BDR list.
Okay, we have a motion on the floor. Is there a second? This is the number one out of these three. The first topic on the three that we were discussing.
I second that. I second Commissioner Rubelid's motion.
Okay, any other discussion for the sake of completeness? Melinda, could you read what we had proposed in that so that everybody understands what we are voting on? This is the item number one out of these three.
Absolutely. So subject one, topic one is requesting that a study be done by an experienced vendor to determine the different strategies and design decisions for a health insurance program for infants, children, and young adults up to age 26 who are ineligible for full Medicaid coverage under federal law due to their current residency or immigration status, to outline coverage options that are primarily state funded. This topic is requesting both the study and funding to support the study. And as Commissioner Vice Chair Ridley mentioned, this is requesting that this be included as a special consideration in the HHS PPC budget to move forward in that fashion, because the PPC does have the statutory authority to contract directly with a vendor. And so we already have that ability, and we would only be requesting the funding, and that would be done through the budget.
Okay, so I think we can proceed with the vote on this one. Raise your hands, those in favor of what was proposed of setting up a committee.
We're voting on this being the BDR that we move forward. I'm sorry. Or we're
This is
moving.
voting as a committee set up, as I understand, not as a BDR.
No, the motion was to remove it as a BDR, but put it into the budget for the PPC as an item for special consideration.
For the PPC committee, not a BDR.
Correct, to put it in the PPC's budget.
Right, right.
Okay, not a committee, a budget item.
Okay. All right, so can we vote on this, please? Those in favor of this setting up a committee under budget within the PPC?
Okay, all in favor, please raise your hands for submitting this as a budget item under the PPC and removing as a BDR. Okay, and let the record reflect, I have 8 out of 9 commissioners that are currently present, raising their hand.
Okay, so the motion carries. We can move to the next item.
Okay.
Read it for the, so everybody refreshed as to what the second item we are voting on.
So the next item for discussion, sorry, is going to be subject to topic 3, which is, I'm sorry, I cannot find my notes at the moment. Here we go. I got it. All right. Before I do this, I do know this, Commissioner Grady, you have your hand raised. Did you did you have a question?
No, my apologies.
Okay, no worries. All right, so the next item up for consideration for a BDR for the PPC is going to be subject to topic 3. This is the BDR topic to address the rising costs created by healthcare market consolidation by prohibiting hospitals and possibly some other facilities such as freestanding emergency rooms from hiring physicians. Revise the exemptions now in law to ensure only community hospitals and academic institutions are exempted. And as we had discussed before, Commissioner Bond had said that we were going to revise that to be only public institutions as well as academic and federally funded institutions. Correct, Commissioner Bond? Excellent. Okay. And so that is the topic up for discussion and vote at the moment.
Discussion was already done. So
Discussion was done.
Proceed to the vote. What we are voting on is those who want this to be presented as a BDR or not.
Okay, so all in favor of subject to topic 3 being proposed to the legislature as a BDR, it's the third BDR for the PPC, please raise your hand. All right, and going to just give it a couple more moments. Okay, Chair, I see 3 out of 9 hands raised.
So 3 out.
Actually, I apologize, we have 10 commissioners at the moment, so I have 3 out of 10.
In support of a BDR.
Yes.
So the motion fails then.
Yes.
10 versus 3. Okay, so that's the item number 2. Let's go to item number 3.
Okay. Item number 3 is subject to topic 6. This topic is to create a prescription drug affordability board, expand on NRS 439B 630, and set allowable rates for certain high-cost drugs identified by the board. Like to entertain a motion to approve this item as the third BDR topic for the PPC to submit to the legislature.
Right, you can call for the roll call for this item.
Call for the vote by
The vote.
hand raise.
Yeah,
Excellent. Okay. I'd like to call for a vote. All in favor of approving subject to topic 6 as the third PPC BDR to submit to the legislature, please raise your hand.
I think Mason's hand was up for both of them.
that's we have item number 3.
His hand is lowered at the moment.
This
Just
is
give it a few moments.
This is the pharmacy board proposal.
Yes. So Chair, please let the record reflect. I see 2 out of 10 commissioners in support of this BDR.
But Dr. Khan, you're voting on this one, so you'd make 3, wouldn't you?
Yeah. So 3 in favor of a pharmaceutical board BDR and the 7 are not in favor, correct?
Correct.
Oh.
So this BDR also gets dropped.
Well, we've only got, so we've only got 2, we're done because we've only got, so we had 3 commissioners vote for each, for number 1 and for number 3. No, for number 2, and then 3 commissioners vote for number 3. Is that how it turned out? Okay. So what are we gonna do? What do you want to do now?
First one was for the letter. So the second option is we can go whether we need a letter or recommendation, at least for the pharmacy board. We can potentially do what we did for item number 1 to create a R committee, subcommittee like we did for the first one, if we were talking about. That's an option short of a BDR.
This is Commissioner Winkler. I wasn't voting. I thought our vote was at the exclusion of the other option. I wasn't voting to disagree with the other BDR. But
Okay.
I'd rather support one or the other. I want us to submit one of these 2.
Right. I think, if I may, I think we should maybe take another vote, knowing now that we both, I don't think anyone wants us to give up our third BDR, right? So
Right.
now we know where we stand.
agree.
I say we do a second round so that one of them at least moves forward, and maybe we do, dare say it, maybe we need a little bit more discussion to help clarify
I think
people's hesitation.
we had a lot of discussion, and the margin of vote differences is what? The last one was 10-3, and the second one was how much?
No, they were both 7-3, Chair.
They're both
7 out of 10, 7-3, 7-3, and the first one was, of course, a non-BDR. So we basically procedurally have eliminated this. Now, if we're going to start all over again, we can keep going. I think everybody has voted rightly or wrongly. If one person has a change of heart, which is understandable, but I think procedurally, it would not be appropriate to keep coming back to a vote when once a vote has been taken and approved.
But Dr. Khan, we have a messed up vote because only 6 commissioners voted out of 10.
I thought it was 7-3, 7-3.
Yes, 3 voted for one BDR and 3 voted for another BDR, and 4 people haven't voted for either. So
And
there's
the
something else going on that we need to talk about, I think.
And the others didn't vote for that BDR, correct?
Chair Khan,
Right.
I know I did not understand
same.
what our vote was going to be counted towards, and I don't think it was clear.
I
Okay.
apologize. That was probably my fault.
Okay, which one were you not clear on?
I have a lack of clarity around each of them, and I just want to ask a clarifying question about a couple of them. In the case of the first one, where we said that we don't need a BDR to make progress there, and could commit budgetarily to it, are we saying through that vote that we have committed to prioritizing that particular policy as a part of the PPC budget? Is that the case? Is that what
That was the motion that I made, correct?
and that passed? So we know that we budgetarily committed to the study as a part of our work here. And so what it comes down to is a no vote on the second two items. And I hear folks saying we don't want to forego submitting a third. And so while I appreciate the commitment to expediency, I would ask us to consider if we could arrive at a third recommendation.
Okay, so let's proceed with that. It's not so much expediency. I just think we need to move on so that everybody is thinking about what we are voting on. So let's start back. I respect the opinion of the commissioners. So let's go back to item number 2 and take another vote whether this should be a BDR or not. Is it everybody clear? We are voting whether item number 2 should be presented as one BDR option, and then we'll vote on item number 3, whether that should be a BDR or not.
Okay.
Quickly, Chair Khan, I do see Commissioner Ralston has her hand raised.
Yeah,
Go
if
ahead.
I can, just for efficiency and clarity purposes, I do have to drop off the call soon, so I apologize to all the commission, but I'd like to just make a motion for reconsideration of topic 2, the one that I supported earlier, with the contingency that the other 2 remaining BDRs on the Drug Affordability Board and for the Medicaid, children's Medicaid provision, I'm just summarizing them, move forward with alternative support options as we have previously discussed.
Second that
So
motion. I second that motion.
So what you are proposing now, if I hear you correctly, Commissioner Ralston, is the item number 3 you want to modify in a new proposal?
No,
No,
my
she's
motion
asking-
is to approve BDR 2, the topic 2 as the commission's third BDR, with the other 2 topics to move forward with the commission's full support in alternative support mechanisms as we've discussed.
So what we should do then is what we were saying earlier, is we are on item number 2. We need to vote, I think irrespective of your proposal, we are re-voting anyway. So we can re-vote on item number 2, whether the commission or commissioners now would like to re-vote on that as the third BDR or not.
Yes, but I would like to move forward with a vote and a motion to vote on that with the additional provision that the other 2 bill drafts move forward in full support. I'm not bill drafts, but the other 2 topics move forward with the commission's full support in the same conversations that we just had amongst the commission. So we all
Right.
supported it in alternative routes. And so topic 2 as the commission's third BDR, and the other 2 to move forward with the commission's full support with the letter and the funding discussions that we had.
So Sarah, there is no topic 2. There's subject 1, topic 1, which was the study. Is that what you're referring to?
No, she's referring to
No,
topic 3.
correct.
So,
Sorry, don't have my notes.
Yeah, that's what I figured. So subject 2, topic 3, is that the one you're referring to, Babette's bill that she explained?
Yeah.
Correct.
Okay. I just wanted to clarify that.
Okay, so let's go to topic 2 now.
Well, this is Commissioner Winkler, and I could be off base, but I think what we want is whichever bill draft request receives the most support, that's what we want to submit. And then the other 2 will receive our support, not as a BDR, but we do not want to lose our third BDR by choosing one or the other.
Correct.
Yeah, that's my understanding as well.
So
And so
let me-
I just want to suggest that if we have any last questions on these, on subject 2, topic 3, or subject 2, topic 6, that we have a shortened time frame to ask those in case people are hesitant to vote for either. And their questions being answered might be helpful, but
I think what the way I look at it is we need to just vote as is. We are re-voting on the original proposals, BDR 1, 2, 3. We
Okay.
should to the BDR proposal number 2, and then vote as is on the BDR proposal number 3. If that gets voted down, then one can go to second option of sending a letter the same as first proposed BDR. So that way it's very clean process.
Okay. I think that would be great, and I don't want to lose a commissioner, so we should just vote, I guess.
Yeah, so let's just vote again for item number 2. Right
Item
now,
2?
yes.
Subject to
Okay.
topic 3.
I've got it. So,
Melinda, you proceed.
so asking for a vote, all in approval of approving subject to topic 3 for a BDR, with the addition that the other 2 topics noted here, if this is approved, that they will move forward with the full support of the commission using alternative routes, being the letter and the funding that the commission previously discussed. So I'd like to call for approval as stated in that sense. Sorry, Tyler, Commissioner Winkler, please go ahead.
Sorry, and just to clarify, we can vote again on the other BDR, and we'll do that after we take this vote.
Yes.
That's my view. I think we should vote them as is, because what we are doing by putting them as already providing an alternative to item number 3, then we are precluding a vote on item number 3. So for example, if we vote on item number 3 as is, if it is voted down, that is fine. Then we can have a proposal to replace it with a letter, etc., like we did for item number 1. But it should be a clear option for BDR 2, yes or no, BDR 3, yes or no. If BDR 3 is still a no, then we can go the other route in a separate proposal.
Okay.
Because we are precluding the commissioners from voting by saying already that 1 and 2 are already going to be resolved under the second option. So just then by default, item 2 is the only one available then.
Yeah, and that's fine too. I just would like to make sure we all get to vote. So are we voting on each one of the 3, or are we just voting on number 2 and number 3?
The one we already voted for, there's no controversy there. So number 2 and then number 3 for the record, complete that also as a BDR.
Okay.
You never know, if you have a tie between the 2, then we'll have to figure it out.
Okay. Revising. All in favor of subject to topic 3 as a BDR for the PPC, please go ahead and raise your hand. Okay, let the record reflect. I see 5 commissioners' hands raised
Okay, and how many total?
out of 10.
Out of 10. So that's 5 in favor and 5 opposed. Or not voting, either or is 5 to 5. Melinda, is it 5 to 5?
We did not call for an opposing vote. Would you like me to call for an opposing
No, I
vote?
mean, if there are 10 commissioners present, 5 are for it, the others have not voted or are not voting for it.
Correct.
So 5 have voted for it, 5 have not for the other one. So that was my point. If there is a conflict, then item number 3 comes up, and if that is voted down, then we'll have to decide with item number 2 then.
So we're going to take a vote on the 3rd topic, right? The drug board now?
Yes, we should take a vote on 3rd topic, see what that comes out to be.
Okay. All in favor of subject to topic 6 being the PPC BDR, please go ahead and raise your hand. Okay, let the record reflect. I do see 5 commissioners' hands raised.
Including the chair.
Including.
Yeah, I wait till the end, so that's where it is.
But that means 6.
Yes, that'd be 6.
Somebody voted twice.
Yes, that was my understanding, that we would be able to vote more than once.
No.
That was my understanding as well.
That's what was said.
So on item
That's what I specifically asked for, and everyone said yes.
number 3, where are we with the item number 3 for a second vote? Melinda, your count.
Dr. Khan, people are voting for both bills.
Yeah,
Right, so but we have separated them out individually, correct?
We tried, but I think it was confusing.
Okay, I'm afraid I'll have to, this is unusual, but you have to do it right. So if there is no more confusion, I think I'll take one last time a vote, and whatever comes out, comes out. I'll go back to item number 2 again, and everybody please vote.
but
And
only
usually-
one
But we
vote.
vote for one or the other, right? We're not voting twice. We vote for one or the other.
May I make a motion?
If we are voting for one and that gets the majority vote, then voting for the third one becomes a moot point. But if both become, if we take a vote on the third one also, and they tie up again, then we have to ask the DAG what to do.
Chair Khan, I think continuing to vote without any discussion is not going to be helpful, because I think we're just making our decision based on all the information we already have. So it sounds like Commissioner McAllister wants to make a motion, so maybe we should hear that.
I make a motion that we go through the roll call and each commissioner either votes for subject to topic 3, subject to topic 6, or abstains and picks one of the 3 options. That's my motion.
Which is fine. Is there a second for that?
I second that.
Okay, any opposed to that process?
I just have a quick question about a clarifying question. Whether we vote for subject to topic 3 or 6, are we saying that if it's not selected, that it will move forward in some alternative process?
We'll come to that in a minute, as Commissioner Austin has mentioned for the pharmacy board part of it. But there's no third option proposed so far for item for the second BDR proposal.
I don't actually think that the topic, the second one, subject to topic 3, has an alternative plan, because it doesn't have a fiscal note, which is what we're trying to resolve on the other 2.
Correct.
So
That is correct. So let's proceed with the roll call vote on item number 2, BDR. This will be the second vote, and I think it will stop at this. But
Okay,
we will take a vote on the third item also, in case they both tie up again, then we'll figure out what to do.
okay, I'll proceed with the roll call vote. So when I
Is
call your name,
everybody very clear in their mind what we
Oh,
are?
we're doing roll call. Sorry. Yep. Sorry.
Is everybody very clear now what we are voting for? Because I'm not inclined to have a third vote.
We're
Is everybody clear what we are voting on item number 2 as a potential BDR?
2 people's hands are up, and I thought we were going to do roll call.
No, it is going to be roll call as proposed. So Melinda, you have to have a roll call.
yes, I'm prepared to do that right now, Chair. Okay, I'm going through the roll call. Please vote for either subject to topic 3, subject to topic 6, or abstain. I'm going to start with Commissioner Ralston.
And my vote is for subject to topic 3.
Thank you. Commissioner Vice Chair Rubelid.
I'm for subject to topic 3.
Thank you. Commissioner Winkler.
I'm for subject to topic 6.
Thank you. Commissioner Tyler Garner.
Subject to topic 3.
Thank you. Commissioner Bond.
Subject to topic 3.
Commissioner Van Houweling.
Oh no, we lost somebody. I was afraid of that.
Oh no, we did. All right.
Try to text him to see if he could get a vote in.
Let's move on in the meantime.
Okay.
Will do. Commissioner Grady.
I think I changed my mind. I'm gonna go with subject to topic 3.
Thank you. Commissioner Roa Dugan.
I'm going for subject to topic 3.
Thank you. Commissioner McAllister.
Subject to topic 6.
Thank you. And Chair Khan.
Abstain on subject to topic 3 for item 6.
I'm sorry, did you say you abstained from the vote?
Subject Item 3,
Okay, and you're voting for topic 6?
that is the pharmacy board one.
Yes.
Yes.
Okay, thank you. Thank you for that clarification. Commissioner Bond, were you able to reach Commissioner Van Helling?
Nope.
Okay,
So we have 9 votes already?
we do. And of those 9, we have 1, 2. Of those 9, we have 6 in favor of topic 3.
So then topic 3 carries for next step on proposal number 3. So this one carries based on the 6 votes.
Phew.
Next one, the item or subject 6, what did we get?
For topic 6, we have 1, 2, 3.
3, 4. So the others are not in favor of that, right?
Correct.
Okay, so that doesn't apply for a BDR proposal. Okay, so that solves this issue. Now the question is what Commissioner Ralston brought up earlier, whether the item, the subject 3 or 3rd proposal of BDR, which has failed as a BDR, should that be considered on a similar lines that we did for the first BDR proposal? Commissioner Ralston, would you like to comment on that? So we can vote on that. You had suggested something.
Yeah, my only suggestion was to move forward with the other 2 in full support of the commission to alternative support mechanisms, meaning drafting the letter and what Commissioner Rubel had stated earlier and putting the PPC's budgetary item in for the first topic.
Okay, so then this is strictly for the 3rd item. Why don't you make a proposal or a motion and we'll take a second and then vote on it for an alternative approach?
So I would make a motion to put forward a letter in support from the PPC on subject to topic 6, rather than a BDR.
I second.
I support.
All right, and so all those in favor, please raise your hands. This should be simple.
Chair Khan, could I? Okay.
Go ahead.
Could I amend the motion to say, and any other activity we can think of on how to get a drug board introduced into the process? I understand this, the interim health may be doing something that we could, use for leverage, according to Commissioner Tyler Garner. So I want the motion to be broad enough that we can keep moving and not just write a letter.
The primary proposer is willing to accept the amendment?
Yes.
Commissioner, yes?
Yes, I second.
And the second person also seconds. Okay, now we can proceed and take a vote.
All right, please raise your hand if you are for. Please note, I see 7 commissioners' hands raised out of 9.
Okay, so that motion carries. So I think enough for the BDR's discussion. We've concluded all of that. So last item on the agenda is public comment. Any public comment in the north or south, Melinda?
I will check here. So if you have public comment, please press *9 to raise your hand, or just use the raise hand feature if you are joining from Zoom. Seeing no public comment, Chair.
Okay, so last item is for adjournment. We stand adjourned. Thank you, everybody, for your time as always. Thank you.